Good morning and a warm welcome to everyone present here today. Honorable Emeritus Chairperson Dr. M. Bansal, President and Vice Chancellor Dr. Aayush Bansal, and my teachers and my colleagues. I, Dr. Aayush Bansal, third year resident, the Department of General Surgery Unit 5 would be discussing a novel technique in the most commonly encountered day-to-day surgical pathology, presenting a case of 23-year-old male with swelling in inguinal region. Under the leadership of Dr. Vijay Sharma sir, Professor Emeritus, Department of General Surgery, Dr. Mahendrapal Kochar sir, Professor Emeritus, Department of General Surgery, Mahatma Gandhi Hospital. Starting with the particulars of the patient, a 23-year-old Hindu male resident of Karauli, Rajasthan, belonging to a lower socio-economic status, presented with swelling in the groin on the left side since 6 months, associated with dragging pain. Patient presented with swelling in groin region on the left side, which was insidious in onset and gradually increasing in size for the last 6 months. The swelling disappears on lying down, but the swelling reappears on standing and increases in its size as patient walks, curves, lifts weights, or squats for definition. Patient complains of dragging pain over the swelling. For the last 7 days, the pain increases with straining and swelling increase as the swelling increases, but the pain subsides with rest and when the swelling gets reduced. He had no history of chronic cough, breathlessness, bronchial asthma, vomiting, fever, burning micturition or nocturia. He had no history of chronic constipation, weight loss or diarrhea. There was no history of similar swelling or in the opposite or the same side. Patient had no operative history and there was no history of any comorbidity or chronic illness. He was a non-alcoholic, non-smoker, non-vegetarian, with a normal sleep cycle, normal bowel and bladder habits. He was not on any long-term medications and had no known allergies. There was no significant family history. What could be the probable diagnosis? As I would like to ask my colleagues. The probable diagnoses include inguinal hernia, femoral hernia, encysted hydrocele of the cord, varicocele, lymphatic, funiculitis, diffuse lipoma of the cord, inflammatory thickening of the cord, extending upwards from the testes or the epididymis, malignant extension from the testes, ectopic or undescended testes, enlarged lymph nodes, or abscess in the inguinal region. On general physical examination, patient was examined in a well-lit room with a proper informed consent in standing and supine position. Patient was conscious and well oriented to time, place and person. Patient was of lean build and had no signs of icterus, clubbing, cyanosis, edema or lymphadenopathy. The vitals of the patient was also normal. Coming to the examination, on inspection, a swelling of size approximately 6 into 4 cm seen in the left inguinal region extending up to the scrotum, pyriform in shape with smooth surface and rounded margins. Skin over the swelling was normal and impulse on coughing was positive. There was a slight deviation in the position of the penis to the right side. Temperature of the swelling was normal. There was no tenderness elicited over the swelling. And the left inguinal swelling of size 6 into 4 cm with smooth surface and rounded margin, pyriform in shape with soft and elastic consistency, is situated above and medial to the pubic tubercle. Testes can be felt separately from the swelling and there was a positive expansile cough reflex present. On Siemens test, it was suggestive of indirect inguinal hernia. There was on lying supine, the swelling was reducible and ring occlusion test was positive. On percussion done in standing position, a resonant note was heard. There was no sound heard over the swelling in the standing position. On systemic examination, abdomen was soft, non-tender. There was no signs of organomegaly. In respiratory system, there were no additional sounds and bilateral air entry was equal. On CVS examination, S1 and S2 was heard and patient was well oriented to time, place and person. Coming to the summary, a 23-year-old male student with complaint of swelling in the inguinal region for the last 6 months associated with dragging pain has an expansile fusiform pyriform swelling of size 6 into 5 cm with a positive cough impulse test. It was reducible and had a positive ring occlusion test. Siemens test was suggestive of indirect inguinal hernia.
एक second, doctor. How will you differentiate between indirect and direct inguinal hernia?
So we can differentiate on by test. Clinical test we can do a Siemens test. On Siemens test we put three fingers, one index finger on this deep inguinal ring, the middle finger on this.
Put index finger or you put the?
No, that is the ring invagination test. That is what that was very uncomfortable for the patients and now been obsolete. We can also differentiate on the basis of the ring occlusion test as well. An indirect inguinal hernia there will be no expansile swelling on occluding the deep inguinal ring, whereas in a direct inguinal hernia there will be a swelling medial to the ring occluded.
How would you tell in a female patient? It's a male patient, but suppose there is a female patient and you have to differentiate direct and indirect. What is the anatomy of inguinal canal?
Anatomy of inguinal canal. Inguinal canal starts from the deep ring to the superficial ring. It is a 4 centimeter structure that ends. The superficial ring lies just above and medial to the pubic tubercle. And boundaries. So anteriorly it is the transversalis fascia. Inferiorly it is the inguinal ligament. Posteriorly.
Inguinal canal बनती क्यों है?
Sir, because of the descent of testes from the
descent of testes से vaginal process
processes
peritoneal period वो आती है.
हाँ जी sir.
That is the reason the inguinal indirect inguinal hernia are more common in male than in female. Female में क्या आता है?
Female में round ligament होती है sir, उसके जो constituent है.
And why there is dragging pain here?
Due to pulling of the mesentery, there is dragging pain. And
पेन तो नर्व से होता है. कौन सी नर्व होती है?
genital.
Now how will you differentiate femoral hernia?
We can do it by the Siemens test only. Also, the shape and size of the swelling is different in femoral and inguinal hernia. It is of a pyriform shape in inguinal or a round shape. It is inferior to the inguinal ligament. Femoral hernia is inferior to the inguinal ligament. It is round in shape and protrudes through the saphenous opening.
Suppose inguinal hernia is large enough and you are not able to differentiate and you have to take the help of ultrasound.
Yes.
What will be the key point to differentiate direct hernia from indirect?
So, inferior epigastric vessels will differentiate.
What will be the relation of inferior?
The direct hernia will arise medial to the inferior epigastric vessel.
Hasselbeck triangle का नाम सुना है?
Yes, sir.
What is that?
Hasselbeck triangle is the site of weakness in the anterior abdominal wall through the direct, which most commonly the direct hernia protrudes.
The complete origin of inferior epigastric artery.
Inferior epigastric.
So if you know that, then during surgery you can avoid complications.
Yes, sir. Inferior epigastric artery starts from the external iliac artery, which then extends upwards towards the abdomen and pierces the rectus muscle at the point of the arcuate line. All routine blood investigations were done and were normal. Chest X-ray was within normal limits and ECG showed normal sinus rhythm. I would like to call Dr. Shivani from Department of Radiodiagnosis to talk about the radiological imaging.
Good morning everyone, I'm Dr. Shivani Ramlani from the Department of Radiodiagnosis. So the first 4 pictures that I've put up here is to make you understand if the hernia is direct inguinal hernia or indirect inguinal hernia. So the first picture that we see here, this is a muscle belly and this is the muscle belly of rectus abdominalis muscle. Inferior to it, so we have turned on the color Doppler setting in this. Inferior to it, we see vessels. So these 2 vessels just inferior to the belly of rectus abdominalis are the inferior epigastric vessels. So once we locate them, we would try to turn the probe a bit medially here. And when we turn the probe a bit medially, what we see is a larger caliber vessels, which are the external iliac vessels. And when we trace these vessels, we would see that these would be connecting to these vessels. So this is the inferior epigastric vessels, which are the branches and draining tributaries of the external iliac vessels right here. After we have localized this, in the third picture what we see, now I've turned the probe longitudinally along the and a bit laterally. When I turn the probe a bit laterally, I find this structure that I've marked in the dashed lines in yellow. This is the inguinal canal. This is the inguinal canal, and those structures that grossly we see in this, the hypoechoic structure that we see here is the vas deferens, and without the color Doppler setting, what we see is the echogenic structure, that is the fat. So the vas deferens and the fat. Now the fourth picture is the longitudinal view of the inguinal canal. So in the longitudinal view of the inguinal canal, what we see is the hypoechoic structure that is lying above. So this is the fat above, and the hypoechoic structure lying below is the vas deferens. So this is a transverse view, this is the longitudinal view. So the first thing that we did was localizing our inferior epigastric vessels, turning our probe a bit laterally. When I turned the probe laterally, I could find our inguinal canal with its contents. Moving further, these are the pictures of a patient. So normally, the inguinal canal should not contain anything else except your grossly the vas deferens and the fat and the vessels. But if you find bowel, like in this case, which was in our patient, this is the bowel along with the omental fat inside the inguinal canal, which is distending the inguinal canal with it. So this was a case of hernia, and this protrusion was coming, as you see here. When I traced it a bit back, this hypoechoic or the dark structure was a deep inguinal ring, and the structures were coming right through it. And this was lateral to the inferior epigastric vessels. So basically, once I have localized the inferior epigastric vessels, the structures were lying lateral to it, and the medial to it is lying the Hasselbalch's triangle. So the Hasselbalch's triangle is formed inferiorly by the inguinal ligament, medially by the lateral border of rectus abdominis, and laterally by the inferior epigastric vessels. So this is a weakness in the anterior abdominal wall, and if there is any defect in this, and the contents would be protruding medial to the inferior epigastric vessels, and that would point towards direct inguinal hernia, which was not the case in our patient. So this was
in the posterior.
Sorry, the posterior abdomen. Yes. So this was not the case in our patient. The next thing what we do, so in this patient, we could already see that the contents were protruding in the inguinal canal. Sometimes it is not. So we do two other things. We make the patient stand up to, if after standing up from supine position, the contents might protrude, and the next thing what we do is we apply the Valsalva maneuver to increase the intra-abdominal pressure. So, even after that, we can see that the contents are protruding. Third, we look for reducibility. If our hernia is reducible or not. So if it's not reducible, we term it as incarcerated hernia or non-reducible hernia. Lastly, we look for signs of strangulation, if the hernia is strangulated or not. And there is where the role of Doppler also sets in. So this is a case where hernia was...
एक मिनट तक, so role of Doppler क्या आपने बात की?
जी सर.
How will you differentiate in inguinal canal on ultrasound between a grade 3 varicocele and inguinal hernia? Suppose that you are not seeing a intestine or other contents in the inguinal
Yes.
canal.
So the grade 3 varicocele, when we put on the color Doppler, we see there are tortuous vessels inside. And when we also ask the patient to apply the Valsalva maneuver, the caliber of those vessels would increase. And it has taken color, so it is not bobble, they are vessels altogether. So yeah, that's how we differentiate it. So another picture that we see here, this is not our patient, but I've just kept this picture for like you guys understand how a strangulated hernia basically looks. This was not the case in our patient. So in a strangulated hernia, basically 1.1 what we see is here. This is, I've turned on the color Doppler here, and what we see here is a whirlpool sign. Can you see that all the vessels are going round and round here? At the neck, basically. So this is the whirlpool sign. First we see this. Second, the content, which is the bowel, we see that the wall of the bowel is quite thickened. So the wall of the bowel would be thickened with the whirlpool sign at the neck. Third, what we see is that the sac contains fluid. So the fluid has echoes within it. So this is fluid and echoes within the fluid, which is it might be infected. And lastly and most important, that because of the inflammation, because it is strangulated, the fat is inflamed. And whenever a fat is inflamed, it looks more bright. It looks very bright. And this is what we see here, the bright fat pad just lateral to the neck of strangulation. So number one, the whirlpool sign, the thickened bowel wall, the fluid with echos, and the fat pad, the echogenic fat pad. So this is the strangulated hernia. And what we measure the neck of it, it is usually narrow, and yes, strangulation is very common, or more common I must say, in indirect inguinal hernia and femoral hernia. And this is the echogenic fat pad that we see in strangulated hernia. This was not the case in our patient. Okay. Thank you so much.
Madam, one question.
Yes, sir.
How can you measure the size of the defect?
Okay. So in indirect inguinal hernia, there is no defect as such, because indirect inguinal hernia is coming directly from the deep inguinal ring. So what is happening is the deep inguinal ring is getting, because it is patent processus vaginalis, and the contents are descending through it. So it is going to widen the deep inguinal ring. So there is no defect, so we don't give the defect size, but we measure, what I'll say is this. How much distension of the inguinal canal it is causing. So if I am measuring, as I would measure this. However, in direct inguinal hernia, there is a defect and we can measure the defect, but not in indirect inguinal hernia. We just give how much distension of the inguinal canal it is causing. Thank you.
So coming back to the case, this is a case of left-sided reducible, incomplete, indirect inguinal hernia containing bowel without any features of obstruction at present. Management of inguinal hernia can be done by laparoscopic approach or by open. Let me tell you the key differences between the two. In open surgery, it can be done under regional or local anesthesia. Only one major incision is given. There is a longer post-op recovery, but it is cheaper and has a shorter operating time. In laparoscopic surgery, we require administration of general anesthesia with 3 to 4 keyhole incision, and hence making it better for the cosmesis. There is less post-operative pain and earlier return to normal life activities, but it is significantly costly. The management of inguinal hernia can be done by conservative method only for the patients who are unfit for the surgery by a truss. It is a supportive belt or undergarment designed to keep the protruding tissue in place to relieve discomfort. Surgical open techniques can be herniotomy done in pediatric age group, herniorrhaphy, that is herniorrhaphy plus repair of the hernial defect, or hernioplasty, that is herniorrhaphy plus strengthening of the hernial defect with a mesh. Surgical laparoscopic techniques include TAPP or transabdominal preperitoneal repair, TEP or totally extraperitoneal repair, or ETP, that is extended view totally extraperitoneal repair. Plan of management for our patient. TAPP was not chosen due to significantly higher risk of injuries to the viscera and the vessels. TEP was ruled out due to inadequate symphysioumbilical length, and hence ETP was planned.
So one question. What is the principle of hernia repair?
So the principle of hernia repair is to entirely, completely place a mesh or completely cover the myobacterial orifice.
What is the principle?
The principle is
Why are you placing the mesh? Why are you placing the mesh?
To strengthen the wall and not to avoid the recurrence. And so basically the principle is not to avoid the recurrence of the hernia.
Basic principle.
Angiotension. Why TEP was not chosen? So basically, if we look at the lower abdominal wall anatomy, the requirements for TEP or totally extraperitoneal repair is there should be an adequate distance between the umbilicus to pubic symphysis. Normal length between umbilicus and pubic symphysis is 17.6 plus minus 3.146 centimeter. And minimum length required should be around 16 centimeter or 8 finger widths. Our patient had an umbilicus to pubic symphysis length of only 14 centimeter, hence TEP was ruled out. Prerequisite and aim for inguinal hernia surgery is to choose the right procedure for the patient, has a low rate of recurrence, low intra and post-operative complications, and a strong and effective repair. It is rapid return to previous customary lifestyle. Satisfactory and adequate mesh placement over the entire myobacterial cortex. Comparison of all the 3 laparoscopic options that are available. the advantages, the transabdominal or preperitoneal repair enables a thorough intraperitoneal examination with visualization of incarcerated or strangulated hernias. It is relatively easier in females with indirect inguinal hernia and has a shorter learning curve. In TEP or totally extraperitoneal, it has the advantage of being an extraperitoneal approach with less chances of visceral or vascular injuries. No peritoneal flap is raised, hence suturing is not required. ETP or extended view totally extraperitoneal repair has all the benefits of TEP plus with an extended view, larger surgical field, improved tolerance to pneumoperitoneum, easier triangulation and easier to teach and to learn. The disadvantages of TAP or transabdominal preperitoneal approach is a peritoneal flap is raised, hence a suturing of the flap is required and there are higher chances of complications. In TEP, there is a limited space for dissection and mesh placement. There is a restricted port placement. No triangulation is there or poor tolerance to pneumoperitoneum. It is a difficult and to teach and to learn. ETP only has one disadvantage, that is it has a longer operating time. By comparison, ETP has got the maximum advantages and minimum disadvantages. Considering his potential to join the Indian Army, the best option offered to the patient was in laparoscopic extended view totally extraperitoneal repair. We went through multiple research articles, recent advances, case reports, technical videos, basically all available material to satisfy our criteria and patient's needs. So starting with the topic, what is hernia? It is an abnormal protrusion of a part or whole of the viscus through a normal or abnormal opening through the wall of the cavity that contains it. Term hernia is derived from the Latin term meaning rupture. The earliest report of abdominal wall hernia dates to 1500 BC. Hernia repair constitute 15 to 18% of total surgical operations. Prevalence of inguinal hernia is 1.7% for all age groups and 4% for above 45-year-old age group. Incidence of inguinal hernia increases in age and mean age at diagnosis is 40 to 59 years and with a male to female ratio of 9:1. The types of hernia on the basis of the location, they can be ventral or epigastric, paraumbilical, umbilical, spigillin. Groin hernias like inguinal, femoral or obturator. Posterior wall hernias like superior lumbar or inferior lumbar or gluteal or sciatic. Classification of hernia on the basis of clinically can be classified as congenital or acquired, reducible, irreducible.
General information for all, even the uterine prolapse, rectal prolapse, they are in the category of hernias. Anything which is protruding from
Is it that hernia is also? This protrusion is termed as a hernia?
hernia, that's
Yes.
just for
Herniation through the vaginal.
Clinically can be reducible, irreducible, obstructed, strangulated or inflamed. On the basis of their content, they can be enterocele, that is containing bowel, omentocele containing omentum, litters containing Meckel's diverticulum, lichers containing a circumference of a bowel loop, Medals hernia containing a W-shaped bowel loops or amens hernia containing appendix. According to the descent can be bubonocele, funicular or scrotal, that is the complete hernia. Knowing the anatomy is mandatory for the surgery and for understanding and performing any surgery, I would like to call Dr. Divija Dutta, Senior Resident, Department of General Surgery.
Good morning, everyone. We will begin with discussion of the anatomy of the inguinal canal. It is a short passage for structures passing from abdomen to external genitalia. It is a 4 centimeter long passage and is of clinical importance as a potential weakness in abdominal wall and common site for herniation. It begins at the deep ring and terminates at the superficial ring, being bounded superiorly by the internal oblique and transversus abdominis muscles, posterior wall being found by the fascia transversalis, anterior wall by the external oblique aponeurosis, and inferior wall by the inguinal ligament. This is the diagram showing the hernial sacs. The hernial sacs arising above the inguinal ligament and medial to it are the direct and the indirect hernias, and that arising below the inguinal ligament, this is the femoral hernial sac. This is the diagrammatic representation of the various types of hernia. We can identify the inferior epigastric vessels here. So this is the Hasselbalch's triangle, and the hernia arising medial to the inferior epigastric vessel is the direct. The one lateral to it is the indirect hernia. The one hernia below the inguinal ligament is the femoral hernia. So the Hasselbalch's triangle, which is a site of weakness through which the direct hernia protrudes. It is a triangle bounded medially by the lateral border of rectus abdominis muscle. Lateral boundary is formed by the inferior epigastric vessels and the inferior boundary by the inguinal ligament. Now we come to the laparoscopic surgical anatomy. To know about inguinal hernia surgery, we must be aware of the myopectineal orifice. It is a weak area of posterior wall composed only of the transversalis fascia. It is bounded medially by the rectus muscle, superiorly by the internal oblique and the transversus abdominis muscle, laterally by the iliopsoas muscle, and inferiorly by the Cooper's ligaments. The principle of inguinal hernia surgery repair is to completely cover this myopectineal orifice with a mesh. This again is a diagrammatic representation of the myopectineal orifice. As we can see, is divided by the inguinal ligament into two parts. The transversalis fascia of Gallorid. It is a thin aponeurotic membrane that lies between the rectus abdominis muscle, the deep layer of transverse abdominis muscle, and the peritoneum. The surgical importance of this fascia is that the internal spermatic fascia must be incised during the separation of oblique inguinal hernia and the sac to expose the spermatic cord structures and the hernial sac. So now I would like to ask my surgical colleagues, can you please tell me that where we are actually going to place the mesh? Okay, so the mesh is placed between these two layers, the superficial transversalis fascia, the deep transversalis fascia, and it will be behind this fat layer, something like this. Now the iliopubic tract, which is a thickened tendinous structure of the transverse abdominal fascia, connecting the anterior superior iliac spine and pubic tubercle. It runs parallel to the inguinal ligament. The surgical importance of this is that no tags should be placed below this iliopubic tract in order to prevent post-operative inguinodynia. The retropubic space of Retzius. This space is formed by the fold of tight fusion of deep transversalis fascia and peritoneum. It includes the bladder and is filled with loose connective tissue. The surgical importance of this again is that no vigorous dissection should be performed in this space as it may lead to injury to the urinary bladder. Behind the pubic symphysis, the space which you can see is the retropubic space of Retzius. Laterally is the space of Bogros, which is the lateral extension of this retropubic space. This is used for preperitoneal access to the foci of anterolateral abdominal wall, whereupon the groin hernias arise. This again is a diagrammatic representation of the retropubic space of Retzius and laterally the space of Bogros. This is an intraoperative photograph of the space of Retzius, the space of Bogros present laterally. The structures we can identify here are the vas deferens, the Cooper's ligament, the left epigastric vessels. Triangle of doom. Doom meaning of terrible fate. It is a dangerous triangle with apex towards the deep ring and base downwards. Medial border is formed by the vas deferens and lateral border by the gonadal vessels. It contains external iliac artery and vein along with the genital branch of genitofemoral nerve. The triangle of pain, which lies lateral to the triangle of doom. The medial boundary is formed by gonadal vessels, lateral border by the reflected part of peritoneum. It contains crucial nerves, namely the femoral nerve, the femoral branch of genitofemoral, and lateral cutaneous nerve of the thigh. To prevent injury to these nerves and post-operative inguinodynia, this region is seldom dissected, and this makes sure that there is no fibrosis and hence no complication. This is also an intraoperative view of the preperitoneal spaces. Triangle of doom is present medially, triangle of doom pain is present laterally. Corona mortis, or the crown of death. It is an anastomosis between the branch of inferior epigastric artery and a branch of the obturator artery. Any injury to this region can cause a torrential bleeding, so it is best identified and laid aside. These are the triangles put together in laparoscopic surgical anatomy. This is the White House, or what we say the pubic symphysis, the Hasselbalch's triangle, triangle of doom, and triangle of pain. Triangle of doom. Triangle of pain. 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 Triangle of pain the arcuate line of Douglas. It is an essential landmark for ET-EP surgeons. It is where the rectus sheath ends and lies somewhere midway between umbilicus and pubic symphysis. Below this line, the rectus muscle is covered only by fascia transversalis and peritoneum. The surgical importance of it is that the inferior epigastric vessels will pierce the rectus abdominis muscle at this point, and it is cut laterally to gain access to the lateral spaces. The pre-peritoneal space, it is bounded by the peritoneum internally and externally transversalis fascia. It contains the fat, blood vessels, lymphatics, nerves, the spermatic cord and round ligament of uterus, which all goes through this. Discussing the case further, I would like to call upon Dr. Aayush.
So coming back to the case, it was a case of 23-year-old male diagnosed with left indirect incomplete inguinal hernia, an aspiring army officer, and was having his physical examination in a few weeks and desired a minimally invasive approach for his condition. ETP was chosen as a procedure of choice in this patient to have the best of both procedures, that is to minimize the complications of TAPP and have the benefits of TEP and TAP. Laparoscopic ETP technique. What is ETP? It is an extended view totally extraperitoneal approach for inguinal hernia. In the field of laparoscopic hernia surgeries, first procedure to be widely adopted was TAPP or transabdominal preperitoneal approach. The revolution in laparoscopic inguinal hernia was the beginning of extraperitoneal approach for inguinal hernia surgery, which was started by Dr. Macron and Laws in 1993. The ETP approach, where an extended view in the extraperitoneal space was done on the principle of TEP by Dr. George Days et al. In 2012, which has the benefits of TEP and with an extended view, enhanced mobility, more working space and many more advantages. The principle of ETP technique. The preperitoneal, every surgery is based on a principle, and principle for laparoscopic ETP, in addition to the principle of conventional hernia surgeries, we have to create a preperitoneal space that can be reached from virtually anywhere in the anterior abdominal wall. The preperitoneal space in the lower abdomen is continuous with the retrosector space beyond the arcuate line. Indications of ETP. We use ETP in most cases, especially in cases with large inguinoscrotal sliding or incarcerated hernias, obese or post-bariatric patients, when the distance between the umbilicus and the pubic tubercle is short, and in patients with history of previous pelvic surgeries. For the new surgeon, ETP is easier to learn as to master. In preoperative preparation, we kept the patient NBM from midnight. IV fluids were started overnight. Part preparation was done in the morning of the procedure. Injection ceftriaxone 1 gram was given after AST, and Riles tube and Foley's catheterization was done. Position of the patient. A patient was laid supine with a 15-degree head-down position with upper limb stuck by the side of the patient. Starting with the port placement. The camera port is placed 5 cm cranial and 3 cm lateral to the umbilicus, the left hand port just below the umbilicus, and the right hand port below the arcuate line and just medial to the linea seminolaris. This is the port placement for the left side. This is the port placement on the right side. Also on the right side of the presentation, you can see that the armamentarium used, the surgeon sides on the contralateral side of the hernia, whereas the monitor is put on the ipsilateral side of the hernia. This is the port placement for bilateral hernias. We do it something like this. This is the port. If we briefly compare the port placement between TEP and ETP, we see that all the ports and totally extraperitoneal repair are placed infraumbilically in the midline, thereby giving a very limited space. Whereas on the other side, ETP has a much higher port placement. This allows us to have an extended view of the space that we have created, and triangulation is achieved. Moving on to the steps of the procedure, we have a checklist of the steps that we generally follow for this procedure. I would like to recommend all surgeons to have a checklist or checkpoints for more surgeries, as it makes the learning curve, learning and understanding the concept of the surgery a lot simpler. So coming to the steps, first we have to create a retrorectus space, then identify a preperitoneal space, identifying and dissecting the space of radius and foregrowths, identifying the direct or the indirect hernial sac, parietalization of the cord, carrying out lateral space dissection, mesh placement of 10 into 15 cm and fixation. I would like to call Dr. Divija again to discuss about the surgery.
Laparoscopic extended view totally extraperitoneal repair. Here we can see the placement of the camera port done with the bevel up. First we will use a 0-degree scope and follow it. Yes, sir. And follow it with a 30-degree scope for dissection. This is the posterior rectus sheath. Now we will be creating a retrorectus space. After creating the extraperitoneal retrorectus space, we will be identifying the landmarks as given in the diagram below. The lighthouse or the pubic symphysis, the space of Retzius, the Cooper's ligaments. We now have to identify the preperitoneal space and visualize the arcuate ligament completely. The arcuate ligament, as I can remind you, is the place from where posteriorly the rectus sheath is deficient. It only contains the transversalis fascia. This arcuate line is identified and it can be cut laterally to gain access to the lateral spaces. Then we will be identifying the White House and dissect the medial space. So this is the intraoperative view where this is the space of Retzius, the space of Borgros. The space of Borgros is then being laterally developed fully. The space of Borgros, as I can remind you, is the lateral space to the space of Retzius. It is a preperitoneal space. After developing the space of Borgros, we next have to identify the direct or indirect sac. The sac is identified by this whitish opalescent structure which we can see. This is the sac. Parietalization of the cord. And we do the parietalization of cord and carry out lateral dissection to create a space for the mesh. The indirect sac should be dissected from the spermatic cord, and care should be taken not to dissect lateral and inferior to the Cooper's ligaments, as iliac vessels will enter the femoral canal at this site. Dissection is completed when the indirect sac is separated from the cord structures. A large indirect sac may be ligated proximally and divided distally. We introduce the mesh through the camera port. This mesh is unrolled and placed over the space so created. M here stands for the medial side of the mesh. We are using a 15 into 10 centimeter polypropylene mesh and usually fix it with tackers. Tackers are applied on the Cooper's ligament and on the upper border of the mesh, well above the iliopubic tract. The mesh is placed to cover all the 4 potential sites of herniation. So this diagram again tells us that no tackers should be applied below this iliopubic tract in order to avoid post-operative inguinodynia. In case of accidental creation of pneumoperitoneum, what we can do is we can insert a 3 mm trocar or a Verey's needle. And for lateral space dissection, we again divide the arcuate line of Douglas. So ETEP, the future, or the potential to become gold standard for laparoscopic hernia repair. This is due to the ease of surgery, the ability to create a good space which is extraperitoneal, ability to place a large mesh. This surgery is easily reproducible and we can tackle large hernias through it. We also achieve good triangulation in this. These were few references which we referred to, which were highly instrumental in our decision making and execution. Take home message. Hernia is the most commonly encountered surgical pathology, which is managed with a variety of approaches, both conventional and laparoscopic. Out of these, we choose what is best for the patient. Every patient is different, every scenario is different. Assess and plan accordingly. As per our experience, we have found that ETEP surgery is the most suitable approach in maximum number of patients and has the potential to become the gold standard of laparoscopic hernia surgery. Patients update. Our patient, now a 25-year-old person, has successfully cleared the army entrance and is now serving the country as an army personnel. He had an uneventful post-operative recovery.